Thank you very much for the invitation, which I'm happy to receive, but unfortunately I can't be in Patras this year. My disclosure: central venous occlusion is really an increasing burden in AV access, and to achieve an AV access or even bringing in a line of central venous catheters can be really challenging in those situations. Especially tunnel catheters are associated in dialysis patients with a high rate of central venous stenosis. The same as with cardiac rhythm devices, and also people which have been really ill and a lot of surgery, for example, like patients with a kidney transplant. Central venous occlusion is a growing healthcare problem because if the right jugular vein is occluded and you can't access it, you mostly go to the left side, and that reduces the ability to place and mature a functioning fistula on the left side. That means increased catheter days, increases patient morbidity, mortality, reduced quality of life, and obviously also an increase in cost. And I will show you now a quick video about the inside out procedure to show how that works.
The Surfacer inside-out access catheter system is a novel approach to gaining venous access from the inside out. The operator navigates the Surfacer from the femoral vein and exits via the venous vasculature. A sheath is advanced over an O35 guide wire to the venous obstruction. It is the conduit for all instruments used during the procedure. After a target is placed on the exit area, the device is advanced into the obstruction. Fluoro is adjusted until the tip of the device is visible within the exit target. The device handle is rotated until the target window appears, and the needle guide is advanced out of the tip. The occlusion acts as a stabilizer as the needle wire pierces the skin at the predetermined exit point. The operator then inserts a sheath from the outside in. The Surfacer is removed, and a central venous catheter or dialysis catheter is placed using standard access procedures.
And here you see how it looks like in reality. You bring in the steel rod over the groin, the right side of the patient, and you adjust the C-arm to have the best view and to bring out the sharp wire at the neck. Adjusting the tube properly is just the key to success. And that has to be done in two different ways to get the best view and to bring out the steel wire at the place where you really want to have the exit. If you adjust the angle properly, place the C-arm in the correct way, then you're able to target the washer on top of the skin really well. Here you can see how the sharp wire punctures the skin from the inside to the outside, exactly in the center of the washer. Then you just grab it with a clamp and you can pull out the sharp wire to bring later in the sheath. We were involved in the SAFE post-market follow-up registry, and 29 of 30 patients achieved the placement of central venous catheters and met the endpoints of safety and performance. And in this cohort, no really adverse events or post-procedure complications were reported in this entire patient cohort. Hemodialysis was the main reason for getting access. Also, nutrition, patient lead, and plasmapheresis were other reasons to implant catheters. Those are the types of occlusions which has been treated in this study. But although we had a great success by using this device, I would bring up some words of caution. Sometimes it's challenging to cross the common iliac vein because of the angle, and I just put up a picture up here to make it even more understandable. In this lateral and anterior view, you see the problem which could occur if you want to cross that with a steel rod, especially if you use the sheath, which is just inside the whole package of the system. We use a braided sheath from now on, and sometimes even two sheath, to bring up the steel rod, because we had this bad experience with the perforation where we nearly punctured the infrarenal artery. So be careful with that. And I would like just to talk you through a case we treated also. That's a male patient with a occluded right brachiocephalic vein. You see the phlebography over there. The device worked well, wire is out, catheter is placed properly, has a nice curve, no kinking, and the catheter worked well for about 7 months. But during removal of the CVC, after about 6 or 7 months, massive bleeding with a pulsatile character occurred, and we had to compress that and rush the patient into the OR. We injected contrast medium via brachial access, and there you see there's some contrast medium outside the vessel. And after achieving femoral access and putting in a diagnostic catheter, you see the former channel of the central venous catheter is filled with contrast medium. Then we could really identify exactly the location of the lesion. After that, we placed a covered stent graft, 8x40 Covera, and sealed the lesion of the common carotid artery. Patient recovered, no stroke, everything is fine. So in conclusion, this device works great and is able to restore central venous access, basically safety when central veins are blocked. And it's quite easy to use by interventional urologists, vascular surgeons, or interventional nephrologists. There are several applications where you can use it, but be aware of potential risks. Thank you very much for your attention.